Assalamu alaikum and welcome to this lecture on oligohydramnios. This could also be regarded as the second part of the lecture for polyhydramnios, so the two of them really belong together, and this is also not going to be a very long lecture. So here we want to also understand what is oligohydramnios, look at the causes of oligohydramnios, look at the implications of oligohydramnios and the possible management of oligohydramnios. So what is oligohydramnios? I asked you, and I know you know this, it is of course little. Oligon means little, and hydramnios again water or amniotic fluid, so it's little amniotic fluid. As we said, normal is 800 to 1000 milliliters at 36 to 37 weeks, and this is also gauged with the AFI, and we'll come to this. The incidence of this is much higher than that of polyhydramnios. It's 4%, and the mortality rate is 5.6%. So this is regarding mortality rate, regarding neonatal mortality rate or fetal demise is much more common with that, with this with oligohydramnios than with polyhydramnios. So oligohydramnios altogether is a more serious problem. Maybe you remember the incidence of polyhydramnios. That's right, it's only 0.15%, of which most are mild, and mild does not really have a lot of implications on the pregnancy. Whereas here you have 4% incidence and a much higher infant or neonatal, perinatal mortality rate. So why is it that the perinatal mortality rate is higher here? We have to come back to the purpose of the amniotic fluid. What was the purpose of the amniotic fluid? To find out why little amniotic fluid is more serious than having more amniotic fluid. Amniotic fluid serves mainly two purposes. First of all, to protect the fetus, and secondly, it gives room to the fetus for development antenatally. So if there was not this fluid around the fetus, the muscles, the strong muscles of the uterus would kind of clamp down on the fetus, and the fetus could not move, and they could also not develop themselves, and you get problems with skeletal development and also with lung development because they couldn't inflate the lungs, which is very important for development of the lungs. So this is why antenatally adequate amount of amniotic fluid is very important for normal fetal development. Furthermore, there's a second problem here, which might occur intrapartum, because intrapartum the amniotic fluid protects against umbilical cord compression, which might occur during contractions. So when in the labor you have contractions, this might kind of impinge and kind of temporarily stop the blood flow from the placenta to the baby and cause compromise to the baby. And if the baby cannot compensate this adequately, you get CTG abnormalities, and we talked about this in our lectures on CTG, and you get also then with time acidosis in the baby, and this will lead to neurodevelopmental delay or problems if it's not kind of acted upon on time. So what happens without amniotic fluid? Antenatally, we have actually discussed this, but this is a bit more detailed list. This can cause compression of the fetal abdomen, and this reduces the movements of the fetal diaphragm, so the breathing movements. Every normal fetus in utero makes breathing movements. I know there's no oxygen exchange through the lungs at that time, and the oxygen exchange is really done by the placenta. But the breathing movements show that the baby is is in good form, and secondly, it shows it allows the lungs to develop normally. If and also it allows for water to shift in and out of the lungs of the fetus. If this is not happening, so if there's no space for breathing movements and no space for developing and growing of the respiratory tract, the lungs, then you end up with pulmonary hyperplasia. And also there might be a problem with or an adverse effect on the fetal heart development. And these are the main problems that you see in fetuses with oligohydramnios in the early antenatal period. Further problems are, of course, the skeletal development, and you can easily imagine that if you do not have the space that the kind of extremities can develop into and move to, then you can end up with bowed legs, clubbed feet, also flattened fasces, so you get a flat face and low set ears, because also the face they cannot develop properly if there's no fluid around them. And essentially also you usually get intrauterine growth restriction, IUGR. Intrapartum, I've already said this, you get poor tolerance of labor due to the cord compression during contractions. So let us look at the different causes of oligohydramnios, and let us look at fetal, maternal, and placental causes separately. So fetal causes can be different ones. They can be poor urine production, which can either be renal agenesis or dysgenesis, so such as polycystic kidney disease. There can be an obstructive uropathy, so that you for example, have posterior urethral valves, so the fetus produces urine, but there's an obstruction and he can't pass it out. And there can be also fetal chromosomal anomalies. This is also something that can be associated with oligohydramnios, and then you would also find some symmetrical IUGR. Placental causes are placental insufficiency, and placental insufficiency is really often associated with other chronic diseases that the mother has, such as diabetes. It might be associated with hypertension or preeclampsia, and also the post-maturity syndrome, which is a time when the pregnancy lasts longer than the 40 days and 40 weeks. Then there's a time after that 40 weeks that the placenta does not actually work as well as it used to, and this is the post-maturity syndrome, and you might get oligohydramnios as part of that. Maternal causes are otherwise rare, so if they might, though, be associated with the use of non-steroidal anti-inflammatory drugs, and these should not be used during pregnancy. ACE inhibitors can cause oligohydramnios, as they cause a constriction of the fetal renal arteries. And also maternal drug abuse, so recreational drug abuse, can cause oligohydramnios. Also smoking can cause oligohydramnios, maternal smoking. One thing that has to be distinguished in any woman who presents with oligohydramnios for the first time, it has to be distinguished if this oligohydramnios is due to either a placental problem, so that the placenta hasn't kind of produced as much, isn't producing as much urine, or the fetus is kind of not excreting urine, or is it due to a loss of fluid around the baby? So basically a spontaneous rupture of the membranes, or as you guys say here, premature pre-labor rupture of the membranes. So this has to be distinguished, and this can be distinguished first of all by a history. So patient has to be asked, have you noticed any loss of fluid? Is there always, are you, and if they say no, I haven't had a gush of fluid, then you still have to continue asking, do you feel wet? Do you have kind of a wetness in the underwear all the time? Or do you have a trickling or small losses of fluid? Or do you wake up with some wetness in your bed? So these are all ways, sometimes a pre-labor rupture of the membranes can go unnoticed. And so you have to ask and see if maybe this is the case, and you have to kind of find out if this was the case. Of course, you can then also do an speculum examination and see if you see any fluid, any pooling of amniotic fluid in the vagina. This has to be, of course, done by a sterile speculum examination. Such a pre-labor rupture of the membrane is often might have an infective cause, it might have trauma as a cause, but what is known is that the risk of chorioamnionitis associated with it is quite high. Different kind of publications cite different risk, but it is you find some citing 21%, others 74%, and a lot kind of other ones in between, but all of these are quite a high risk for infection. So, what history is it important to take in this case? If a patient presents with oligohydramnios, and we already said you have to ask for symptoms. So, have there been any symptoms? Have you noticed any trickling of fluid? Have you lost any fluid? Often they say no, and there hasn't been any fluid loss or any other symptoms. So, what do you ask? Wetness, constant wetness. You have to also ask for any problems in the pregnancy. So is there a history of hypertension, diabetes, connective tissue disease, all of which can be associated with oligohydramnios? How is the obstetric history? What happened in previous pregnancies? Have you had preeclampsia, HELP, anything like that, gestational diabetes in previous pregnancies, so that you have a higher risk also in this pregnancy? So you have to therefore check the presentation, do exclude or diagnose a loss of fluid via a leakage, or rupture of membranes, and you have to also, of course, assess the baby. Often with oligohydramnios, especially the chronic form, the long-standing oligohydramnios, often babies might also be small for dates, and often the presentation is within the routine antenatal check that a patient comes and she appears small for dates, and then a kind of subsequent ultrasound scan reveals her to have oligohydramnios, often together and associated with also a smallish baby. So if you then examine her, you would find that a reduced symphysis fundal height, and you would find that fetal parts are very easily palpable. So this is the opposite from severe or significant polyhydramnios, where you cannot really easily feel the fetal parts. In oligohydramnios, you can feel them very well. You have to always ask yourself, are there any fetal movements? So you can ask the mother, but you can also watch for yourself. Do you see any fetal movements? And then you have to do the sterile speculum examination to see, is there any leakage of urine, of liquor? If yes, what color is it? Is there any blood? Is there any odor? So if it's been a while that they had trickling of fluid, is there an infection? What other investigations need to be done? You need to check the blood pressure. This is very important because oligohydramnios and IUGR is often associated with placental problems, and one of the placental problems is, of course, preeclampsia. So you need to check the blood pressure and urinalysis. Also, other blood tests are important here, like FBC, UNE, urate, and LFTs. This is the full picture you want to get if there's a risk of preeclampsia that hasn't really had clinical signs yet. Ultrasound scan needs to, of course, be done to confirm oligohydramnios and also measure it and quantify it. If it's less than 8, if AFI, we also use the AFI. If you have an AFI less than 8 centimeters, you have suspected oligohydramnios. If it's less than 5 centimeters, it's significant oligohydramnios. If you have it less than 8 centimeters, you have to keep an eye on it and see what happens. Does it get less, or is it kind of actually around that stable? Is this normal for this baby, or does it get less? And you have to look at the full clinical picture, which of course includes a good anatomical survey of the baby, as well as a biophysical profile to see how is the baby actually doing. Is it doing well, or is it kind of somewhat stressed? So you have to look at fetal growth. You should do uterine artery Doppler and umbilical artery Doppler to see the kind of blood flow to the placenta and to see how the placenta actually is working. And you absolutely have to do an assessment of the fetal kidneys, the bladder, and the collecting system to actually make sure there's, or to identify any problems that might be there. So here you can see some of such problems that might be seen in the ultrasound scan. The ultrasound scan with oligohydramnios can be very challenging because the amniotic fluid actually poses a contrast and makes us view anatomical features and organs better within the baby. It makes us see the anatomical makes us identify anatomical features easier. So in polyhydramnios, it is often possible to actually see, get a very nice picture of the baby. But in oligohydramnios, this is not the case. In fact, the opposite is the case. But here you can see some examples of things that you might find. So on the left, you see cystic kidneys. So first of all, the top picture shows you normal kidneys. You see there in the middle, you see the spine. This is a cross section of the abdomen below the stomach bubble. So the stomach bubble is above, and this is below the stomach bubble. You see the fetal spine very well here, and it leaves a little bit of a shadow in the middle of the round abdominal section. And on both sides there, next to the spine, you see the kidneys, 2 kidneys. If you look to the other pictures here, you find cystic kidneys are actually easy to see. So Potter 1, you see a few kind of cysts in the kidneys, and then 2 and 3, you see more. In Potter 2, you see one cystic kidney, the other one maybe some cysts, maybe normal, and then in Potter 3, you see both have kids again more cystic, so larger and more cystic kidneys. On the other hand, you see hydronephrosis. So borderline hydronephrosis is actually something that is not too unusual in pregnant women. This might be due to, of course, it might be due to an obstruction of the renal outflow tract, so the urinary outflow tract. But it might also be due to just a relaxation of the renal outflow tract, and this might be due to the progesterone effect during pregnancy. So hydronephrosis is not always abnormal, especially if it's only borderline, but more significant hydronephrosis, such as you see in the picture on the right, with very significantly raised kind of dilated ureters, is usually abnormal. So here again, a little reminder of how to measure AFI, and I have explained it I will not repeat it now. I have explained it in the recorded lecture on polyhydramnios. And this is a picture of oligohydramnios. And here you can see how difficult it might become to actually do a good ultrasound scanning with polyhydramnios, how it is much more difficult. You see the placenta is so the abdominal wall is at the top of this picture. A little bit down you see kind of the fatty layer, the subcutaneous fat layer, and then below that you see the placenta, and below the placenta is the fetus and only a very small amount of amniotic fluid. And here's another picture. These pictures are just here to illustrate the challenge this might actually be for you. Here are different kind of sections measuring AFI. You can see different kind of sections measuring AFI, and you can see that this is a little. So if you find oligohydramnios, and I'm now not talking about pre-labor rupture of the membranes, I'm now talking about oligohydramnios due to other causes. It is very important to assess fetal well-being because this oligohydramnios might be due to a malfunction of the placenta, and malfunctioning placenta or a malfunctioning uteroplacental unit, or insufficient or uteroplacental insufficiency is also a problem for the baby and will also cause harm to the baby if it kind of continues for a long time. So here you can see that it is very important to assess fetal well-being, and this has to be done very regular, 2 or 3 times a week, depending on how serious the situation is. Serial measurements have to be done of the fetal growth to check how this happens. And also other diseases, of course, have to be treated, such as diabetes. Although diabetes is commonly associated with polyhydramnios, if it is very severe and very poorly controlled, it might also be associated with oligohydramnios. And also blood pressure needs to be treated very well. Sometimes people are asked to do oral hydration, but this has probably only a small effect on the oligohydramnios. But karyotyping is important, as especially if oligohydramnios is associated with symmetrical IUGR, then it is a possibility that you are dealing with a karyotype problem in the baby, a genetic problem in the baby. It is very important to plan for the delivery. So you have a baby here that has oligohydramnios and that might have IUGR. So you have a stressed baby. So you do not want to leave the baby in utero until it dies in utero and you deliver a stillbirth baby. No, you want to deliver this baby when it is still alive and still well, without any, has not yet suffered from acidosis or such problems. However, you want to keep it in utero as long as possible because you want to reduce the problems this baby might face if it's delivered prematurely. So you have to deliver the baby as late as possible, but you have to deliver it as early as necessary. This can only be done if you regularly observe this baby, and this should be done on a fetal-maternal medicine unit, where this patient should be seen at least 2, maybe 3 times a week for biophysical profiling and an assessment of how the baby is doing. And if you see any deterioration in those factors, then a baby has to be delivered. You should give steroids for fetal lung maturation, and you have to know that meconium staining in these circumstances is often present also in the babies at delivery. Some I have to say that when you plan the delivery of such a baby, the usual way to deliver these babies is by cesarean section. But just for completeness, I do add that some babies, some people might prefer a vaginal delivery, or knowing the problems that this might lead to. And then it is possible to do an amnio infusion. So an insertion of a fluid prior to the delivery, so that you can then this can then kind of reduce the risk of cord compression and fetal distress during labor and at delivery. This might also be useful if you can't see much on the ultrasound scan. An amnio infusion can also help to improve the ultrasound picture for better fetal assessment. Prognosis in oligohydramnios is not as good as it is for polyhydramnios, actually. If you find renal agenesis, there's a 100% mortality rate, infant mortality rate. Okay, so they might survive and be delivered, but after delivery, they cannot survive. If oligohydramnios is mild, the prognosis is usually good if delivery is timely. So if the delivery is kind of well timed, so not too early to cause problems with prematurity, but also not too late to cause deterioration in utero. Severe oligohydramnios that kind of starts early on, so for example 27 weeks, 30 weeks, even 32 weeks, it might lead to pulmonary hyperplasia, renal failure, and also cardiac problems because of the impact that the severe oligohydramnios has on the baby. So what is important in these babies postnatally? They have to have, of course, a very good neonatal assessment. So the fetus has to not only have they need the normal examination of the newborn, but they need imaging as well. So they need imaging of the urinary system and the GI tract. They need an ECG, they need an echo to kind of check that the heart is developed well. They need chromosome testing to kind of see if there's any problems, genetic problems here. And in very severe cases, and if hemoglobinopathies are not known, then the mother needs also to be investigated for hemoglobinopathy. So at this point, I ask if you have any questions. But to summarize, oligohydramnios occurs in 4% of all pregnancies. It has a mortality rate of 5.6%, so a high mortality rate. Patients need to be carefully monitored and managed, and also the management of other chronic illnesses such as hypertension, diabetes, preeclampsia needs to be optimized. Fetal surveillance has to be carefully done, and including the fetal anatomy survey is essential. And in order to have a good outcome for these fetuses, a timely delivery is also essential. Thank you very much.